Yes, sir. Good morning, all my senior and dear colleagues. I'm going to share upon on my our institutional experience on correlation of echocardiography and cardiac catheterization in evaluation of patients with single ventricular physiology and their impact on surgical decisions. As we all know that with the better availability of better non-invasive test and easy availability of ECG, X, and echocardiogram, role of the diagnostic cardiac catheterization has become very much limited, except for the fact that inadequate anatomical delineation or disturbance with the branch P anatomy or something related to therapeutic intervention, most of the people are doing cardiac catheterization in case of a single ventricular physiology. In our study, we did the cross-sectional study over 114 patients up to the age of the 18 years with the diagnosis of a single ventricle who underwent the echo ECG and surgery in the same sitting. Coming to the result and analysis, in our study, we could correlated well between the echo and cardiac catheterization finding in among the branch pulmonary artery. In our study, out of 114 patients, we could not enter the pulmonary artery in 52%, and rest of the 62% we could enter the PA and could measure the direct pulmonary arterial pressure. Among that, 18% showed PA pressure of more than 15, while 34% showed PA pressure between 10 to 15, while 10% shows PA pressure of less than 15. While among 92%, we could enter the pulmonary vein and measure the indirect pulmonary venous wedge pressure, where 12% showed PA pressure of more than 15, while 37 showed between 10 to 15, while 43 showed less than 10. While the same finding which was correlated with the gold standard per operative finding, where 73% showed PA pressure between the 10 to 15, while 20% showed PA pressure of more than 15, while 12% showed PA pressure of less than 10. In our study, out of 114, PVRI was between the range of 1.5 to less than 1.5 in 27%, while between the 1.5 to 3 in 35%, while 52% we could not enter the PA, so could not measure the PVRI. Now, these findings were correlated well with the per-operative gold standard finding, where PA pressure, which was estimated with the direct PA entry, while as well as PA pressure, indirect PA pressure estimated via pulmonary venous wedge pressure, both of them correlated very well with the direct per-operative pressure, which was measured during per-operative period, and it was correlated very well with the McNamara test with the p-value of less than 0.6 and 0.3. We did another study that the patients with prior PA pressure of more than 15, we tried to show the correlation with that of a per-operative gold standard PA pressure estimation, where we could see that out the patient where we could enter the pulmonary artery and measure the PA pressure, where more than among patients with more than 15 millimeter of mercury PA pressure, 13% showed the more than 15 PA pressure in per-operative finding, while one patient didn't show PA pressure more than 15 in cath, but somehow it showed the PA pressure of more than 15 in per-operative investigation. Among the
Dr. Nihar, please
yes, sir.
just one concluding statement. Your time's up.
Sorry, sir. So, as we can say that majority of the hemodynamic and anatomical details gathered via the non-invasive test correlated well with the on-table surgical finding, which will guide us in selecting cases that need invasive tests, and thus we can avoid subjecting the majority of the patients to undue stress and the complication of invasive tests, sir.